Hi, everyone, and welcome to CCO Club Webinar number 20. And today we're going to talk about surgery on the female genital system. And a lot of the coding that we will go through for this particular system, I will have a lot of pictures, some actual pictures, but a lot of them are just diagrams to give you a visual. This happens to be, this OBGYN is my ultimate favorite specialty to code for, and right now I don't have any that I'm coding for, unfortunately, but it is my favorite. But it took me a while to understand a lot of how to code in the system, because some things are bundled in and whatever. So I do say that in this particular coding, I do rely heavily on the National Correct Coding Initiative, simply because there are a lot of situations and scenarios where you can't bill for this, but you can bill for that, and so forth. So the question that came up was actually, can you please provide examples of surgical procedures on the female genital system? I get so confused. So first of all, depending on what specialty, it's best to know all your terminology, but if you're just working like with a particular specialty, I would definitely get to know all the terminology for that specialty. And a skilled coder will have a good understanding of the terminology and know how to dissect the documentation. You want to make sure you know your prefixes, your suffixes, and the root words used in the operative notes. And most of you who have been studying or have studied for the CPC exam and are familiar with CPT are aware that there is a condensed list at the beginning of the CPT manual that can serve as a reference. And what I do if I'm working on a specialty where some of those root words aren't there, I just write them right in to help myself along. So some of the basic terminology for the gynecology, the female genital system. And we have otomy, which means incision or cutting into. Then, of course, we have ectomy, which is excision, surgical removal. Sometimes you'll see the term revision, and that all means the same thing. I can never say this one. Orifice, whatever. Suture, surgical repair. Centesis is the puncture to remove fluid. Scopy or scopy is viewing with an instrument. And then we have urea, which is flow. So the prefixes that we will be looking at a little bit today and that come up a lot if you're billing for gynecology is colpo, which is vagina, hystero, which is the uterus, salpingo, which is the fallopian tube, and then the oophar, which is the ovary. And I just threw a couple of abbreviations in here so that you could become familiar. Amnion is the amniotic sac surrounding the fetus, which is the bag of water. The BTL stands for bilateral tubal ligation. Then BUS can stand for Bartholin's, which is typically the cyst, urethral, or Skene's glands. And those are glands that are located on the anterior wall of the vagina around the lower end of the urethra. And then we have CPD, which is a term, cephalopelvic disproportion, which is basically a baby's head or body that's too large to pass through the mother's pelvis. There's also other terms like, the transverse and so forth, where the baby is in other positions. But this one I just shared with you. Chorion is the placenta, which provides nutrients to the fetus. Then you have enterocele, which is vaginal hernia, where a portion of the small bowel extends into the rectovaginal space. You will see a lot of references in gynecology that refer to this, or rectocele and stuff. Gravida is the total number of confirmed pregnancies. Parity is the number of live births. And you will see that a lot, in OBGYN. And LEAP, very common. I have a lot of family practices that I code for, and a lot of the doctors do colposcopies, and they'll do the LEAP procedure, which is the loop electrocautery excision procedure. We have the LTSC, which is low transverse cesarean delivery, procedentia, which is prolapse, SAB is a spontaneous abortion or miscarriage. A TOL is a trial of labor. A TOT is a transobturator tape, which is a sling. And basically, it's a small incision that is made in the wall of the vagina, and the permanent tape is introduced via the vagina to sit under the urethra, and the needles used to place the tape are introduced through small incisions of both sides of the upper inner thigh, and the tape used is a permanent mesh which will not be dissolved in your body. And then the tension-free vaginal tape, which is also a sling, is basically the same thing, but the tension can be adjusted. So if a woman you know, that's had multiple births, and it happens a lot in older women, if their vagina or whatever, it can just start dropping down, or it can come through rectally or whatever. A lot of times women cannot carry their babies, and slings are put in as well so that the baby won't, you know, fall out. And that's basically what those slings are for. Now, the first section we're going to talk about is the vulva, perineum, and introitus, and it's incision and drainage. Now, 56405 is incision and drainage of vulva or perineal abscess, and that is the first picture where you actually can see this is the perineum right here, and this is the rectal area, and here is the perineal abscess. And then the 56420 is used to report an incision and drainage of a Bartholin gland, and this is an example of one in the female anatomy. Now, I have to tell you that I remember one day when I was billing for an OBGYN down the Cape, and I remember waiting for her to come out and have a meeting, and I heard this woman scream in her office while I was waiting for her. And when she came out and says, "Oh yeah, I just stabbed that Bartholin gland cyst." And I was like, oh my gosh, I almost fainted, because that poor girl, I don't know what she did, but she was in a lot of pain. And that's, so basically she just, you know, cut and drained it. But she obviously was rough. All right, so now we'll talk about destruction in the same area. So 56501 is destruction of lesions. It's in the vulva area, simple. And the examples are laser surgery, electrosurgery, cryosurgery, or chemosurgery. And that is a simple destruction. The 56515, the destruction of lesions, vulva extensive. Again, we have the laser surgery. The example below is the electrocautery surgery or electrosurgery, and that's a high frequency electric current to heat and cut tissue. Cryosurgery, chemosurgery, that's when they chemically remove the tissue. And here we see the codes, and you can just see this is the device and where it's removing the vulval lesion. And I am going to stop here for 1 second to tell you, Whitney, that congratulations. I wanted to ask you when I was praying you were coming on tonight, and that's a tough exam, so I'm very proud that you were able to pass it. And I'm happy that you're still here. So congratulations. Now, the next surgical procedure that is done in the female genital system are the biopsies. The biopsy 56605 is of the vulva or perineum, which you see right here, and it's for one lesion. Now, after you code for this, if the physician has actually biopsied more than one lesion, you will be adding this add-on code 56606, and it's the biopsy of vulva or perineum, and it's each separate additional lesion, and you list it separately in addition to the code for the primary procedure. So if they did 3, you have 2 options. One, you can do the 56605, and then you can do 56606 and do times 2 units, or you can do per line. So it could be 56605 and then 56606, 56606. Some payers are very, very particular, but I find that the majority of them will accept it either way. So anyways, this is a picture of a biopsy being taken, and there's the little scalpel. So, and it says that a tissue sample is taken from a lesion located on the external female genitalia, or the area between the anus and the vagina. And that's the perineal section. Now, endoscopic examination magnification, and we're still in the vulva perineum section. The 56820 is a colposcopy of the vulva, and it describes endoscopic examination and magnification of the vulva to evaluate for viral lesions, neoplasia, or malignancy. So the very first picture here, it's a little fuzzy, but this is the colposcope here. And as you can see, it has a light at the end of it. The speculum is inserted into the woman to open up the area, and the light beam goes in, and this is the vagina, the cervix, and the uterus right here. A colposcope is used to examine the external female genitalia, but if a biopsy is taken instead of the 56820, it would be 56821. And so this is basically, this is this side of, you know, where the colposcope would go, and this is the side view. Now on the 56821, it is the colposcopy of the vulva with biopsies, and it describes the endoscopic exam and magnification, which is the same service of the vulva to evaluate for the viral lesions, neoplasia, or malignancy. If multiple biopsies are performed on the vulva during the same session, you're only going to report this code one time. And the reason you would, this is the key here, is that it's indicated by the optional plural form, biopsy or biopsies. So that is not a per line or per unit. That's only a one-time code. Okay. Wow, Whitney, that's a good grade, 86. That's amazing. That's amazing. Okay, now let's talk about the vagina and destruction. 57061 is destruction of vaginal lesions, simple. So for example, we have the laser surgery, the electrosurgery, as we had talked about before, which is the heat, you know, it's heat. Cryosurgery is the freezing, and then the chemosurgery is the chemical removal of the tissues. And then we have the 57065, which is the extensive version of the destruction of the vaginal lesions. And here we just see the same diagram where we have the lesion here. So here's the cervix, here's the lesion, and here's the vaginal canal right here. And the physician would use this device to destroy the lesion. So this is an example of the electrocautery device. And like the cryosurgery piece of equipment, you know, a little bigger and so forth. This is the example that I found. Now, one of the things to keep in mind is the determination of whether a procedure is simple or extensive is really based on the clinical judgment of the doctor. So the method and technique of destruction listed in codes 57061 and 57065 includes, but is not limited to just laser, electro, cryo, or chemosurgery. But in this case, I just wanted to show you, here is, I mean, many of you as kids have had children that had warts, and you know they just kind of freeze the stuff on the wart. And when it's happening in the female anatomy, they have the tank with the coolant, the cryo gun, and the cryo tip, which actually goes in to the vagina. And you can see another example here. And this is actually the cryosurgery, the freezing of the lesion. Now, when we talk about excisions, again, we have the biopsy of the vaginal mucosa, simple, or 57105, biopsy of vaginal mucosa, extensive, which would require suturing and include cysts, okay? And the vaginal mucosa is basically mucous membrane of the vagina. So here is pretty much the same picture, but the biopsy, physician takes a tissue sample from the vaginal wall for examination and diagnosis, and that would be the tool that would be used. Now, there's another heading under the vagina in the genital system, and it's called introduction. The introduction codes in this anatomic site include the diaphragm or cervical cap, which is CPT code 57170, fitting and insertion of a pessary or intravaginal support device, which is 57160, and introduction or irrigation of medication or hemostatic agents into the vagina for injuries or infection, and those codes are 57150 and 57180. Now, the 57170 is the diaphragm or cervical cap fitting with instructions. So you would never link, even though there's with instructions with it, you would not link an E&M if the patient came in for this. And this is a picture of the physician fitting a prophylactic device to the patient's unique anatomy. And this is the diaphragm or cervical cap fitting with instructions. The fitting and insertion of pessary or other intravaginal support devices. The device is inserted into the vagina to provide structural support for the uterus. And this is such a common thing. I really never realized it until I started coding for OBGYNs. And basically, you just see, this is the female anatomy, and the pessary goes right in here, and it's, or the structural support, and the doctor just pushes it in. I'll give you more information on the pessary and how to code for that, because it's very, very strict rules with that, but I'll touch on that in a second. The 57150 is the irrigation of the vagina and or application of medicament, thunder, for treatment of bacterial, parasitic, or fungoid disease. An agent that promotes recovery from injury or ailment. It's a medicine, so that's medicament. So here we have irrigation of the vagina, the uterine canal, the vaginal canal, the cervix, the endocervical canal, and this is the injection device. So this is basically a douche, and it may be treating the bacterial, parasitic, or fungal disease. And basically the physician washes the vagina with the fluid and or applies medicine to treat the infection. Now, the introduction of any hemostatic agent or PAC for spontaneous or traumatic non-obstetrical vaginal hemorrhage is 57180. And here it shows the physician packs absorbent material into the vagina to control bleeding. And this is a retrieval loop, which means that when the patient goes back in, once the bleeding is stopped, there's a loop there, and they will go in, they'll put the speculum, they'll put the little tongs, and they'll catch the loop and then pull out the packing or whatever. Now, when you're fitting for the pessary, you're going to be coding for two things. First, we have the fitting and insertion of the pessary or other transvaginal support device, and that's at 57160. But in addition to that, the doctor is actually going to supply the pessary, and it comes in two forms. One is rubber, any type, and the other one is non-rubber, any type. So we have A4561 as the pessary rubber and A4562 as the pessary non-rubber. Now, according to CPT, they're saying that it is appropriate to report the supply item with CPT code 99070 or the HCPCS codes that you see here. I will say that the majority of payers that I have worked with prefer the HCPCS code for the pessary, even private payers. I very rarely get paid for 99070 because it's too generic of a procedure. But if you get denied for HCPCS, then at that point, you would know a particular insurance prefers it. But when you're billing for the fitting and the insertion of the pessary, you want to make sure you bill for the supply as well. And here are some examples of what a pessary will look like depending on the female anatomy and the type of problem. Now, let's see. What if a patient had an IUD removed in the emergency department? How would you code for that? I'm going to be covering that very shortly. And would you use an E&M code for an ER visit and an additional code for the removal of the IUD? That, Whitney, would depend on the situation. If it was embedded and you're making a decision to remove it, absolutely, I would bill for it. But it's sometimes, well, it depends on the situation, because I do code for a lot of emergency visits, Cape Cod and the islands, and a lot of the services that are performed in the ER can actually or should be done in the doctor's office, but because of limited staff and physicians, a lot of times it's treated like it's an office visit. But typically, if you go to the ER, it's usually for a problem, just not to have the IUD removed. And I actually cover a scenario about that. So it would be a decision to have it removed, especially if it's embedded into the vagina. So I will show you that shortly. But anyway, so this is the positions for insertion and removal of the pessary, which a lot of women are able to do for themselves. However, many patients, especially the elderly, will go in and they will have it removed, have it cleaned and refitted. And you cannot bill for that. You can only bill an E&M. However, if there's a problem and it doesn't fit right, and the doctor is refitting and sizing, measuring, and then inserting a new pessary, then you can bill for the insertion as well as a new supply code. But if the patient just comes in because they want the doctor to do it, that would fall under just simply an E&M service. The diaphragm or cervical cap fitting is the 57170. So as indicated in the code description, instructions to the patient regarding the use of the diaphragm or cervical cap are included when this code is reported, and separately report the supply item with the CPT code 99070, which I don't encourage, or the appropriate HCPCS level 2 code, which I do encourage, and that's A4266. And that's for the diaphragm, and A4261 is for the cervical cap contraceptive. And here we have pictures of the diaphragm and what the various birth control methods, such as the diaphragm. Spermicide goes in, and then the inside, like the cup of the diaphragm, and then it is actually inserted, and that prevents sperm and egg from meeting. This is what a cervical cap is, and the cervical cap blocks sperm from entering the cervix here. Okay, so that's basically what they look like. Now, insertion and removal of the IUD. The 58300 is the insertion of the IUD, and here we have the 58300, which is the insertion, and if the doctor removes it, it's 58301. And the typical IUD design is a T, and as you can see, it goes up to the vagina, there's the cervix, the IUD goes right here. And you know, the doctor, again, will open the area with the speculum, and when they put it in, it's like all folded up, and then it opens and goes ping. So the patient might feel a little ping. It doesn't really hurt. And then when it comes out, most patients don't even feel it. When you bill for the insertion of the IUD, you want to find out if the doctor, in fact, supplied it, because it costs the physician a lot of money. It averages about $900 for an IUD. And a lot of doctors don't like being left not being paid for it if the patient's insurance doesn't cover it, or something like that, or if the patient ends up being liable and then they don't pay for it. So, I mean, if you bill $900, you will get $900, and if they don't give you that or whatever, you just appeal it with a copy of the invoice and you would get paid. So you would be billing for the 58300, the insertion, and these are the current 2018 HCPCS level 2 IUD codes. And we have the Kylena, the Loletta, the Marina, the Copper, and the Skyla. And those are basically the IUDs. Now, some doctors I know will bill for the insertion, but they write a script for the IUD, and the patient picks it up at the pharmacy and they deal with it. So you don't want to bill for the IUD if the doctor didn't supply it, but most cases they do. So, and those are the ones you want to follow when you're doing your follow-up, because you don't want to lose out on that, because that's not billing $900 and having the insurance allow $600. They reimburse the doctor for the total amount. Oh, absolutely right, Stephanie. And you don't want to forget that with every one of these J codes, I'll move up, you want to go to the National Drug Code section, you know, Google it. And when you put this in, you want to make sure that you get that NDC code, because when you set it up, it has to appear, you know, on the CMS 1500, whether paper or electronic. And the insurances are becoming more and more strict with these NDC numbers, not just with the IUDs, but with a lot of medicines and vaccines that they never required them before, and now they're insisting that you use it. So it's a good one website to have an icon on your desktop for, so that you can constantly look it up. And it's good to also have the invoice, because the NDC code is usually on the invoice, because a lot of times different manufacturers, whether it's drugs or whatever, they definitely will have different NDC codes associated with it. So I'm glad you said that, Stephanie. Good call. Now, here we have the removal of the IUD, and that's the 58301, and it's basically the same thing, except, you know, the speculum, and then they go in and they pull that out. So again, I have a scenario about removing the IUD. Now, sometimes patients come in, their IUD may have expired after 5 years, so the doctors remove it and they bill for that. And then they want a new one inserted. So you can also bill for the insertion as well as the removal. Make sure you use your modifier. And then again, the HCPCS J code if the doctor supplied the IUD with the NDC number. Now, when we talk about manipulation, the codes under the manipulation heading include codes to report pelvic examinations, but they're all under general anesthesia. So we have 57410, then we have dilation of the vagina, 57400, and then removal of vaginal foreign body, 57415. And again, these are all performed under general anesthesia. A pelvic exam performed with a local anesthetic or without any anesthesia is not reported separately. It would just be included in the level of an EM service reported for the visit. And I know a lot of people will say, well, gee, you know, when the doctor does a wellness exam and they do a PAP and a pelvic, well, there are specific criteria associated with the pelvic, and it's actually a breast and pelvic exam. So, and again, they're referring, these codes are referring to manipulation under the general anesthesia. And this remains true for removal of impacted vaginal foreign body without anesthesia as well. So let's look at the pelvic exam under anesthesia. And here, the physician administers a non-local type of anesthesia and examines the female reproductive system through the vagina. So the right hand palpates the top of the uterus by pressing on the lower abdomen. And any women who have had, you know, these exams in the doctor's office, they understand. And then the left hand palpates the cervix through the vagina. And that's how a lot of times the doctors will feel the ovaries and things like that. But this code, again, is only associated with being under anesthesia. Now, when we're dilating the vagina, again, it's under anesthesia, and instruments of increasing size are inserted into the vagina. So the physician puts the patient in an unconscious state with general anesthesia. Next, the physician inserts a device into the vagina to enlarge the vaginal passageway. I don't even know if I've ever coded for one of those, but just, the patients are unconscious. Now, the removal of impacted vaginal foreign bodies, again, is under anesthesia. And here you see the speculum that's inserted. There's the vagina, and then the foreign body is being removed with these little tongs or whatever they're called. Are they called forceps? I don't even know. They look like scissors to me. And some examples would be tampons, vaginal suppository, medications, or even broken portions of condoms. And I've coded for a few other things that I cannot mention on the webinar, but they have, for example, in this particular case, it would be an emergency room visit. Sometimes it's vaginal, sometimes it's anal, and whatever. And it's definitely a decision for surgery. And then you have the removal. And it's usually under anesthesia. But these are some of the most common ones here. Now, when we talk about endoscopies, we know that endoscopies enter the body through a scope, not an incision. Well, I shouldn't say that, but it's through a scope. And under the heading of endoscopy, 57420 and 57421 are intended to report endoscopic exams and magnification of the surface of the vagina. And it's performed for those patients with conditions that include an abnormal pap smear or a prior hysterectomy with cervix removal and abnormal pap smear. Examination of the attached portions of the cervix performed as a part of the endoscopic vaginal exam are included and not separately reported. So even if the doctor is examining the surface of the vagina, if he is looking at other parts that are attached to the vagina, it is not coded separately. When we talk about the colposcopy, which is an endoscopy, the first code is 57420, and this is of the entire vagina with the cervix present, with cervix if present. And then the 57421 is the colposcopy of the entire vagina with cervix if present, but it includes biopsy or biopsies of the vagina and cervix and/or cervix. So it's telling you in the guidelines, if you look these codes up for colposcopic visualization of the cervix and adjacent upper vagina, they would tell you to use 57452. When reporting colposcopies of multiple sites, you want to use modifier 51 as appropriate. For a colposcopic exam or procedure involving the vulva, it's telling you to see the 56820 or 56821. And if the exam is with the cervix, it's telling you 57452 or 57461. Now, with the colposcopy, it's telling you that if you also do an endometrial sampling, and again, I'm going to be giving you examples because I have some coding scenarios, which is a biopsy and it's performed in conjunction with the colposcopy, you would be coding the 58110 with the colposcopy, but I'll show you that shortly. Now, the colposcopy of the cervix, including the upper adjacent vagina, this procedure describes a diagnostic colposcopic exam. And it's here where it says you don't want to report this code in addition to the 57454 through 57461. And again, I can't stress enough, when you're billing for these and coding, use your National Correct Coding Initiative, because a lot of times I even think, I can build this and I can build this together. And in fact, you can't. So the guidelines are very important, and you will find that when you put certain codes together, the guidelines on Find a Code or Supercoder, or even in your CPT manual, they will tell you what you can and cannot use. But here's another picture of the colposcope, and this is the external opening, and this is the biopsy forceps. And a colposcope is inserted through the vagina to the cervix, allowing the physician to visualize the cervix and the upper vagina. Now, the 57454, which is another colposcopy of the cervix, including upper adjacent vagina with one biopsy or multiple biopsies of the cervix, and endocervical curettage, which is means it's the collection of cells. Just to give you an example, this code, Medicare allows $169.54. So between Medicare's payment and the secondary payer, if there is one, at 20%, the doctor should receive $169.54 in total for this procedure. But again, you want to note that the language of the code indicates biopsies, so you only would use this code once. Now, if only a biopsy of the cervix is performed, it would be appropriate to report code 57455, and that reimbursement is the $159.95. And then if only the endocervical curettage is performed, it would be appropriate to report the 57456, and this was less money, it's $151.01. So this one, as you see, it's including the upper and adjacent vagina with one or more biopsies of the cervix, as well as the endocervical curettage, which is the collection of the cells. So this one you get more money for. It combines, where if it's broken up and only one of these is done, you would code for that. Now, the 57455, just remember it's biopsies of the cervix, and the 57456 is the endocervical curettage. And the codes 57454 through 57461, they are further differentiated according to the biopsy method. So excisional loop electrode. So you will see like a breakdown in your CPT of the different ways that you can code for this, because the method will be listed. And here we have, and this is copied right out of Find a Code, but when you look up colposcopy of the cervix, including upper adjacent vagina, you can see all the codes. So the 57452 is the colposcopy of cervix, upper adjacent vagina. The 57454 is the cervix biopsy, and that's cervix and endocervical curettage. The 57455 is the cervix, upper adjacent vagina with cervical biopsy. The 57456 is the colposcopy cervix with the endocervical curettage. The 57460 is the colposcopy cervix, vaginal loop electrode biopsy of the cervix. And then the 57461 is the colposcopy of the cervix, the vagina, and that's the electrode conization cervix. So here is what the loop electrode biopsy looks like. And this is used, the 574, to report the loop electrode biopsy procedure of the cervix performed at the same operative episode as the colposcopy. And the physician views the vagina and cervix through a colposcope right here. This is the scope right here, and this is the electrosurgical loop and the speculum. And a hot cautery wire is used to excise a cone or section of a cervical tissue and cauterize the area at the same time. And this is an actual picture of it being done. And I know that just about every patient that I've ever spoken to has said it's a very painful procedure. Saying. So the loop electrode conization procedure 57461, it consists of a procedure performed to obtain a large tissue specimen from patients with abnormal pap smears in which a portion of the endocervix, and this is most typically in the transformation zone, and the transformation zone, that means it's a common area of changing cells in the cervix where the abnormal cells typically appear, and that's called the transformation zone. And this tissue is excised where a distinct lesion has been visualized on the endocervix. Typically involves a use of a loop electrode to excise a lesion on the ectocervix, and that is the lower part of the cervix with adequate margins, and then subsequent use of a second loop to remove the involved portion of the endocervix, the inner part of the cervix. Now, in the 57461, the colposcopy of the cervix, including upper adjacent vagina with loop electrode conization of the cervix, and the guidelines tell you do not report this code in addition to the 57456. And for endometrial sampling or biopsy, it's performed in conjunction with the colposcopy. You would also use the 58110. And again, this is the loop electrode biopsy. That's the scope where the doctor will be looking in with a stream of light. And this is the cervix, and this is what, like a conization, this is what comes out of the cervix. This is what it looks like. So a colposcope is inserted through the vagina to the cervix, allowing the physician to visualize the cervix and the upper vagina. The physician then removes the lesion by placing a loop around the target site and passing an electric current through the loop, which helps to remove the lesion and prevent bleeding. So, and that's why it's called loop electrode conization, because it's pretty much shaped like a cone. Within the cervix uteri codes, and these are codes that we're going to talk about, the heading is cervix uteri in your CPT manual. Within the codes 57452 through 57800, one will find subcategories of codes for procedures that describe endoscopy, excisions, repairs, and manipulations. So code 57520 describes an excision of a cone shape of endocervical tissue, the conization of the cervix by means of a cold knife or laser without a colposcopy. When code 57520 is reported, fulguration, which is a destruction of small growths, dilation and curettage, which is your D&C, or repair performed is also included in this procedure and not reported separately. Okay, so it can get a little confusing because you will see, different procedures with, D&C or fulguration in it, and so you want to make sure that you understand that. The code 57522 describes conization of the cervix, and this technique is by loop electrode excision. It's used to report an excision of a cone shape of the endocervical tissue by means of the loop electrode. This is a different, less complex procedure than conization with a cold knife or laser. Separate codes are used to differentiate between the techniques. So if a loop electrode biopsy is performed with a colposcopy, you're going to code the 57460. If the colposcopic loop electrode conization would be reported with code 57461. So it's telling you that if it's a loop electrode biopsy with a colposcopy, it's 57460. But if it's a loop electrode conization with the colposcopy, it's 57461. Codes in the corpus uteri series, the 58100 through 58120, describe providers that involve in excisions. So 58100 is the endometrial biopsy with or without endocervical biopsy without dilation. And 58110 is endometrial biopsy conjunction with colposcopy. And then the 58120 is dilation curettage, diagnostic and therapeutic, non-obstetric D&C. Okay. Now, the introduction codes within the corpus uteri series include the insertion and removals of the IUD 58300 through 58301. Introduction of catheters for diagnostic purposes. Example, let's see if I can say this. Hysterosalpingography or hysterosonography, or to establish patency, which is looking in the fallopian tubes to see if they're obstructed or not. And these codes would be 58340 and 58345. So the 58340 is the catheterization and introduction of saline or contrast material for saline infusion. And you'll notice here we have sonohysterography, SIS, and yet it's also referred to as hysterosonography. So depending on what your doctor does or documents, and then, or hysterosalpingography. And the 58345 is the transcervical introduction of fallopian tube catheter for diagnosis and or reestablishing patency, any method with or without the hysterosalpingography. So that being said, these codes also have radiology codes associated with them, 76831, 74740, and 74742. Now the 58340, the catheterization and introduction of the saline or contrast material, the guidelines will say for radiological supervision and interpretation of saline infusion, sonohysterography, use 76831 with this code if that is done when the doctor is doing this procedure. For radiological supervision and interpretation of the hysterosalpingography, use 74740. The 58345, which is the transcervical introduction of the fallopian tube catheter, their guidelines will say for radiological supervision and interpretation, use 74742. Now, several codes exist within this anatomical heading, all right, and relating to fertility medicine. And some that are included would be artificial insemination, which is 58321 and 58322, and sperm washing for artificial insemination, which is 58323. So the 58321 is artificial insemination intracervical, and then the 58322 is artificial insemination intrauterine. And here is a picture of the intracervical, the fallopian tubes, the ovary. We see the cervix, the vagina, the acorn tip injection. So here's the push syringe, going through here, through the vagina, and the semen injection site is right here. So the physician inserts a plastic tube into the opening of the cervix. The plastic tube is connected to a syringe containing semen. Now, several codes also exist within this anatomical heading related to fertility medicine, okay? The 58323 is sperm washing for artificial insemination. And here we have a centrifuge, washed sperm in a solution for artificial insemination. And is performed prior to, okay? So if the doctor does this in the sperm washing at the same time, if you look at the correct coding initiative, it will tell you you can build them together. There are no NCCI edits. Now, the remainder of the codes under introduction include chromotubation, which is injecting colored liquid through the fallopian tubes of the oviduct. And that's the tube through which an ovum or egg passes from an ovary. The 58350 is the insertion of Hayman capsules for clinical brachytherapy, which is insertion of capsules into the uterus for placement for radiation therapy. And then we have 58346, which is thermal endometrial ablation, and that's just removing the endometrium. The 58353, endometrial cryoablation, which is freezing rather than burning the endometrial lining. And then if you code it with ultrasonic guidance, you would use 58356. So it's really important, you know, like I'm showing you examples, but you really want to like go through the CPT and see it. So here we have the 58353, which is the endometrial ablation, thermal, without hysteroscopic guidance. And for the hysteroscopic procedure, you would use the 58563. And this involves an inflated balloon catheter through the vagina into the uterus, which can be heated to a high temperature to ablate the benign tissue associated with benign menorrhagia, and that's dysfunctional uterine bleeding, a very, very common problem with women. And this is a diagram of an endometrial ablation thermal without the hysteroscopic guidance. And here is the inflated balloon inside the uterine cavity. Here's the catheter, the cervix, and this is done without the hysteroscopic guidance. Oh, I masker this terminology. I apologize, but I'm notorious for it. So 58563 is the hysteroscopy surgical with the endometrial ablation. And this involves the use of the hysteroscope and utilizes an electrode loop, a roller ball, or a laser to ablate the tissue. So here, again, we have the uterine cavity, here's the cervix, and here is the hysteroscope. So a surgical hysteroscopy with endometrial ablation is performed using any of the different techniques available, such as an endometrial resection, which is a resection as an excision, cutting out, electrosurgical ablation, or thermoablation. Now, the hysteroscopy is the inspection of the uterine cavity by endoscopy with access through the cervix. It allows for the diagnosis of intrauterine pathology and serves as a method for surgical intervention. This is what I can't even think. Well, this is a hysteroscope. I'm getting tired. All right, and this is how it would be inserted to examine the uterus. It's a tool. Okay, I'm a little late. In addition to procedure 58563 listed previously, many other procedures can be performed with the use of a hysteroscope. Now, 58558 is a hysteroscopy surgical with the sampling biopsy of the endometrium and/or polypectomy, and it means with or without the D&C. Okay, a D&C is commonly performed with a hysteroscopy. Thus, both procedures are described in a single code. So here we have a hysteroscope is used to check the uterus for injury or disease, and polyps tissue samples may be removed. So here is the scope again, and it's going in, and here is the polyp. Now, the wording, the 58558, is worded this way to make it clear that when there is a sampling, a biopsy, or carotiding of the endometrium and or a polypectomy is performed, the D and C should not be recorded separately. That's very important. And I think it was 58120. I could be wrong. So you wouldn't be doing this and then adding this, the DNC code. It is bundled in, as we saw in the wording. Additionally, since a biopsy sample can be obtained by a DNC, the code also represents a hysteroscopy with biopsy. So I have a few coding scenarios to go through with you just to give you a visual. The first one is a physician performed a colposcopy with a biopsy of the vulva and a colposcopy with biopsy of the cervix during the same session. How should this be reported? When multiple colposcopies are performed during the same session, each should be reported separately to indicate that the colposcopies were performed at different anatomical sites. It would be correct to report both. So you would code 56821, which is the colposcopy of the vulva with biopsies, and then 57421, colposcopy of the entire vagina with cervix, if present, with biopsies. And according to the guidelines and the National Correct Coding Initiative, they're saying that modifier 51 can be appended to the secondary procedure code to indicate that multiple procedures were performed during the same session. Now, this is the NCCI edit for Medicare. And as you can see here, no edits means that we do not have to add the modifier 51 to these two CPT codes. So we have the colposcopy with the RVU of 492, and this one is the 56821, the colposcopy of the vulva with the RVU 462. No NCCI edits for this code. Now, when you look at these codes again, you want to look at some of the top modifiers billed to Medicare, and 49.15%, and again, this is from Supercoder, they're saying that multiple procedures, so is used a lot. And when multiple procedures other than E&M services, physical medicine and rehab, or provision of supplies are performed at the same session, so forth. You know, and it's really funny because for me, I'm thinking, well, it's the vulva and it's the vagina. And in my mind, I'm thinking it should be modifier 59. But according to everything that I'm seeing from the guidelines in your CPT manual, as well as the Correct Coding Initiative on Find a Code and Supercoder, they're saying that it should be modifier 51 if it's required by a payer. Medicare does not require it. The 59, that is a distinct procedural service under certain circumstances. It may be necessary to indicate that a procedure or service was distinct or independent from another non-EM service provided on the same day. So who's to say what other gynecological procedure might have been done where you would add the modifier 59, but the majority of the modifiers is the modifier 51. So I'm not sure if you're familiar at all with findacode.com. I go between both of them. I love them both so much, so I subscribe to both. But it really, between both of them, I get a lot of information, but it's also in your CPT manual. Now this one, can I report code 57160, fitting and insertion of a pessary or other intravaginal support device if a patient comes into the office to remove, cleanse, and reinsert pessary? And I touched on this before. If a patient comes into the office to have her pessary removed, cleaned, and reinserted, the appropriate E&M should be reported based on the key components of history exam and medical decision making, as this is considered part of an E&M service. So, you know, between 99211 and 99215. It would not be appropriate to report this code, 57160. It would not be appropriate to report this, as the code is to be reported for the initial fitting and insertion of the pessary or other transvaginal support device. So in order to report this again, a new pessary would have to be refit, and the physician would have to measure and supply a new pessary supply with either the rubber or non-rubber supply. And so I remember that when I first started coding and I did this, I think I used to code for a new one. And when I started to study coding I realized, oh my gosh, I shouldn't have been doing that. The insurance paid, but it was like, when I realized, it was like years later, and I went, oh my goodness. So just remember that, yeah, insurance might pay, but if you're audited, that's not cool. So only if you're getting refitted and measured would you use this code again. Otherwise, you would just use the E&M. So this is a little bit off topic, but it does relate to billing obstetrics. Why do you have to bill 0508F, postpartum delivery follow-up, after a patient is delivered if the code is $0? In this case, will the provider get paid for the postpartum delivery follow-up since it is $0? That is informational, statistical reporting, and there are no dollar amounts, but it is related to the quality reporting, so that those codes that are sent in, they have to meet so many criteria. And then the doctors ultimately get bonus checks, like from Medicare or from the insurance companies, but it's really more of like the quality reporting codes, and you don't get paid for it from the insurance carrier. But ultimately, like say for this particular specialty, they may need to have to do within 6 or 7 months, they may have to use that code, say 20 times or 10 times. And if they meet that criteria, they get points for that. And then they get a nice fat check. And I mean fat, like $30,000, $40,000, $50,000. I mean, that's why it's so important that the doctors understand about these codes. But as far as you as a coder, you have to report it, but you would put the dollar amount. Some softwares don't even like having $0. They make you put 1 cent, and then you have to go in and write all those pennies off. But it's really a reporting code more than anything. But the doctors do benefit if they fit the criteria for quality reporting. So I hope that makes sense. We don't bill the insurance companies on these. We file self-pays. Okay. Postpartum delivery follow-up. So usually the postpartum, that's all bundled in to the delivery. That's the antepartum, and then the delivery and postpartum and stuff. But sometimes there are problems associated post-delivery, and of course then you would bill for a visit. But these are definitely quality reporting codes. Now, when reporting 57421, colposcopy of the entire vagina with cervix if present, with biopsies of the vagina cervix, is it okay to presume that endometrial biopsies are also included in this code? Per the AMA guidelines, for the endometrial sampling or biopsy performed in conjunction with colposcopy, use the 58110. And you will see here when you look it up that it says list separately in addition to the code for primary procedure. So here in the guidelines, it says use 58110 in conjunction with, and they list 57420, 57421, 57452, 57461. And this one, they're asking about the 57421. So it's saying you would add this with this. Now, here is what is the appropriate CPT code to report for the removal of an embedded IUD using a hysteroscope, curette, and forceps. The answer is 58562, which is hysteroscopy surgical with removal of impacted foreign body. Now, the physician inserts a hysteroscope in the uterus to check for injury or disease. You know, and again, the polyps tissue sample may be removed, or an impacted foreign body is removed. So to answer your question from before, if the patient is going into the emergency room, she obviously is having a problem, and it may be embedded or whatever, but the doctor is going in and basically seeing the patient, you know, on an emergency room basis. And so typically you would bill for the emergency room service, and then bill for the surgical procedure. A lot of times what happens is, and you know, that would even be true in a doctor's office if this was the case. But for example, we have patients that want to get pregnant after they've had an IUD for 3 or 4 years, and they call and they just tell the doctor, I want to have an IUD removed because I want to get pregnant. then you don't even bill an office exam because you just bill for the surgical procedure, because part of that quick exam to check where the IUD is and remove it, that is all bundled in. The part of that service is bundled into the actual surgical procedure. But if it was a problem, whether it's the ER or the patient went in because it was embedded or you were suddenly bleeding or something, obviously that takes more of an exam, medical decision making, and you would bill for an E&M with that, with the decision to do the procedure. So it really all depends on the documentation. But if it's just someone, even that goes into the emergency room and says, hey, take out my IUD, I want to get pregnant or whatever, typically that's just the surgical procedure. So there usually has to be some type of a problem in the decision to do the procedure. I hope that makes sense. Okay. Now, a 60-year-old female reports a vulvar lesion. An examination of the vulva and perineum discloses a 0.5 centimeter dysplastic appearing lesion. A vulvar biopsy is warranted to evaluate the etiology of this lesion to determine appropriate treatment. What CPT code should I use? Well, we would use the 56605, the biopsy of the vulva or perineum, one lesion. And this is the tissue sampling. I showed you this before, where the doctor just comes in and surgically removes the lesion. And for the additional lesions, for that code, for this particular biopsy, you would either, if it was 2 or 3 more, you would use the other code. And I think it's 56606. And it would either be 2 units, 3 units, depending, or you could do it per line. Either one is acceptable unless a particular payer disagrees with you. Then you follow their guidelines. So basically, we reviewed some of the surgical terms for the female genital system, and we looked at some of the CPT codes and illustrations so you could visualize the various procedures. And we learned what the code, some of codes, what we can and cannot code together, and gave you some coding scenarios. I hope that helped. I don't know if you have any more questions. Hopefully that made some sense, because I know that there are so many procedures that can be done. So like I said, I strongly recommend that you use your National Correct Coding Initiative, read your guidelines, and know what you can and cannot bill together. And we follow all of the guidelines, but as always with billing, we always will have some payer rules that are different. And then you just make notation of that for the future. So let's see. No questions here. So I've been told to bill the postpartum follow-up separately. Is that correct, or should it be bundled in with the delivery? For example, the patient delivered on May 1st and the patient had a postpartum follow-up on May 2nd and May 3rd and Dr. B, and then they were discharged on May 3rd. Sometimes the postpartum is done by a different physician when the one who performed the delivery. Well, that's a different scenario, because let's say it was a vaginal delivery, 59400. That includes the antepartum, the delivery, and the postpartum for 6 weeks, okay? But if one doctor does the antepartum and delivers the baby, and another doctor in the group, because a lot of these OB/GYN groups have a bunch of doctors that see the patient, and whoever's on call ends up delivering the baby. If they're all part of the same group, even though it's a different doctor, typically you would bill the 59400 after the postpartum visits, and whoever the last person was in that group would be the one that you could use as the provider, but the group gets the money anyway. But I have a lot of patients from Martha's Vineyard in Nantucket, and over the years, when I billed for obstetrics, a lot of people would vacation, say, on the islands, and they were from New York. So they would be seeing their doctor in New York or whatever, and have a couple of office visits while they were on the island. The doctor could bill for that separately. And then, it all depends, or you move, or your insurance changes. It's like the scenarios are really different. That's why, and a classic example is that my youngest daughter is expecting her second baby, and she's leaving Massachusetts at the end of this month and moving to North Carolina. So the doctor that she's seeing in a couple of days is only going to bill for the one E&M service, and then she's gone. So he can bill for that obstetrical visit using an E&M code, but then her new doctor will bill for the remaining. So if you really have to pay attention to the descriptions. So if this is an OB/GYN practice that has 5 doctors, yeah, you wouldn't be, that would all be bundled in, because each one of those doctors, unless they're billing under their own individual tax ID numbers, typically on a claim form, whoever provides the service, in 24J, you'll see the individual NPI number for the doctor, and then the group NPI number, let's say it's, you know, Boston OB/GYN group, that group NPI is at the bottom. So it's saying that doctor from this group saw the patient, and that group in box 33 gets the check. But it's telling the insurance company who the doctor is. So, but if they're all individual doctors that are billing under their own individual NPIs, but they're sharing an office, then definitely he would be able to. But if he's part of the same group and using the same tax ID and group NPI, then usually the rule of thumb is that whoever does the postpartum, the last person that to see the patient, will bill the global, and his name would go on it, say if it was the 59400 for the vaginal delivery, but the group would get it, and all the notes and documentation would point to, you know, it being a group taking care of the patient. That's very, very common. But you haven't been questioned, so I don't know. But see, you have to also remember that there are people that have babies that have problems after they have the baby, and that absolutely would be a different circumstance, and you would code for that. So it's all relative. I mean, if it's just basic postpartum and, you know, there's no other diagnosis, then I'm surprised that you would get paid. But if it's, you know, like say hemorrhaging or some type of complication post-delivery, then that's definitely warrants an E&M service. So I hope that helps. But usually it's all inclusive. If you look at the words antepartum, labor and delivery, and then postpartum up to 6 weeks, and that's all inclusive. And if you Google that under Medicare or so forth, it's amazing. It really breaks it all down. Blue Cross Blue Shield, it even tells you how to bill and code for twin deliveries, groups, individuals, and so forth. And they give you so many examples of coding scenarios, so I think it would be beneficial. Now, the diagnosis is usually 080, so the patient had no problems. And you get paid, Whitney, still? Interesting. Okay, well, a lot of insurance companies would not pay for it and say that it's bundled into the main procedure. And that happens a lot when I code surgeries. If I don't have documentation, I just have an operative note, and I don't know, you know, if the patient was seen by the doctor before, was it a decision for surgery, or, you know, if he had another procedure and he's returning, because a lot of times they don't indicate that it's a complication or a different problem or whatever. So, but if it's just, you know, so if another procedure was done prior to by another provider and we bill within the global period, we get denied, and then we do research or call the office and say, you know, what was done. But fortunately now, with access to the electronic medical records and being able to read a lot of stuff, we're able to see if procedures, what was done by other doctors at different dates, so that we know the appropriate modifiers. But I would be interested, maybe the next time if you come on, let me know about that. I'm going to do more research on that too. I might even touch on it at the next club next week, because I want to research that a little bit more. But anyway, that's that. So kind of interested to see. But I'll get more detail on that if you're going to be around. If not, you'll probably have access to the club anyway. But once again, Whitney, congratulations on passing. Make sure that you let CCO know so they can announce it next Thursday at the monthly webinar, so you can be acknowledged, okay? So I guess that's it. I will research this too, and if you're here next week, I'll have some info and we can share our information and then share it with anybody that's watching, all right? So have a good night, everyone, and I will see you next week. Thank you for joining me, and my thunderstorm has passed, so I survived. I'm glad I didn't lose you. See you next week.